I'm Dr. Kaladhar, Head of the Department Critical Care Medicine from Yashoda Hospitals, Malakpet. Welcome to our Tuesday webinars from Department of Critical Care Medicine, Yashoda Hospitals in association with IDCCM Hyderabad chapter. So we bring forth these sessions every Tuesday. Alternate Tuesday is the master class, wherein students present the cases and our top expert panelists and who are being examiners, they will be there and guiding them. And it's like as actual the exam, how it goes in the real exams, the session will go on like that. And most of the students are given their feedback that during their examination, these sessions they do watch and they acted like a reference to them while preparing the exams. So, and even the practicing clinicians told that some important principles that they learn from here, especially the management perspective, are helpful. With this, today I welcome Dr. Suresh Ramasubban, sir, as a senior consultant, critical care medicine from Apollo Hospitals, Kolkata. We know sir very well. Sessions wherever the conference, I am very eager always to listen to sir sessions because they are very what to say, live and very interactive type of sessions. And I welcome you on board, sir. Thank you for joining with us. And probably in a short time, we will be with us. Dr. Ritesh will be joining. But yeah, anyway, later he will join. Once he joins, we welcome him. So today's topic of discussion: acute respiratory distress syndrome. So I think this is a complex disease. Day in and day out, being an intensivist, we do see these patients very regularly. And during COVID pandemic, we had seen a lot of patients. I think everyone got exposed to the severe ARDS cases and a lot of management dilemmas at that point of time. But yeah, we do see these patients very regularly. To present this, we have an interesting case presented by Dr. Harish Kumar and Dr. Rohan Katta. Both are IDCCM residents from Mahatma Gandhi Medical College and Hospital, Jaipur. So Dr. Venkat Raman Kola sir is also there on board. And Dr. Ritesh joined. Welcome, Dr. Ritesh. Yeah, Dr. Harish and Dr. Rohan, probably you can start the session. We'll go ahead.
So PPT you will be sharing, sir, or we need
to? You can share from your side. If you're having any difficulty, probably we'll share from our side. We have a share screen option, no? Yeah.
Yeah, good evening all. Sorry, I was a minute late. Hi,
yeah,
Suresh.
fine, sir.
Hi, Ritesh, how are you?
I'm
That's
fine.
all right. I think we're right on time. No issue.
Yeah.
Yeah. Yes, it's yeah, we are able to see your slides. Yeah, they're clear.
Good evening, everyone. Myself, Dr. Rohan Katta, and Dr.
Good evening, sir. Myself, Dr. Harish.
We are going to present a case of ARDS. A 17-year-old male polytrauma patient with traumatic brain injury and post-decompressive craniotomy, which was done on 6th Feb, status was shifted from shifted to ICU from HDU on 13th Feb, which was the 7th post-op day, after a rapid response team call with the chief complaints of difficulty in breathing and fever. The patient had a history of present illness. The patient had associated history of road traffic accident, which was a motorcycle collision. Took primary treatment at the local hospital in Alwar. From there, he was shifted to the Mahatma Gandhi Hospital for further management later on the same day. Patient underwent right frontotemporal decompressive craniotomy on 6th Feb 2024 for raised ICP. And the patient had Glasgow Coma scale, which was improved to E4, V4, and M6. He also underwent surgery for right shoulder reduction, and he was ongoing the treatment in wards. The patient was apparently all right till morning of 13th Feb until he developed shortness of breath which was gradual in onset and progressive in nature. He was initially breathless while he was mobilized to the bathroom. Later on, it progressed to the breathlessness while talking, for which he was taken on oxygen support and a rapid response team was called. Patient also developed fever, which was of high grade, intermittent in nature, and was associated with chills and rigor since morning. He was given paracetamol and fever was relieved by it. The patient doesn't have any breathlessness on lying down. Patient doesn't have any paroxysmal nocturnal dyspnea. There was no history of palpitation and chest pain. He doesn't have any complaint of decreased urine output, and there was no history of any burning micturition. The past history, the patient doesn't have any history of diabetes mellitus, tuberculosis, bronchial asthma, hypertension, and stroke. On surgical history, the patient had operated for right elbow fracture 6 years back. Personal history, the patient is a student by occupation, vegetarian by diet, regular bowel bladder habits, patient had Foley's catheter in situ, non-alcoholic and non-smoker. There was no history of any allergy with medication. Temperature, on general examination, the patient had 99 °F temperature. He had pulse of 132 per minute, which was regular with normal force, volume, and tension, no radioradial, no radiofemoral delay. There was no apex pulse deficit, and all peripheral pulses was palpable. He had a blood pressure of 80 by 60 millimeter of mercury in right arm supine position. He had a respiratory rate of 40 per minute and SpO2 of 82% on 10-liter non-rebreathable mask. He was a normal weight, moderately nourished, with a height of 5.6 feet, and his calculated body weight was 66 kg. There was no pallor, icterus, clubbing, cyanosis, lymphadenopathy, and edema. On systemic examination, on respiratory system, there was no obvious external chest injuries noted, normal shape and symmetry of the chest. The patient had abdominal thoracic type of respiration, respiratory rate of 40 per minute. He had an excessive use of accessory muscles present. Chest movements were bilaterally equal and there were bilateral basal capitations present.
You can stop now.
Yes, sir.
So let me just ask you, so what are you thinking right now? What is the differential diagnosis of somebody who is hypoxic and hypotensive?
Sir, patient can have pneumonia. He had a fever and he was breathless.
So, see the question
Pneumonia.
forward. So you stick to the answer.
Yes, sir.
What are the things? So pneumonia is one thing. Pneumonia with sepsis. So how will pneumonia with sepsis and ARDS with multi-organ failure? That's fair enough. One differential diagnosis. What else?
Patient might be having a ARDS like pictures on pneumonia is the one of the differential diagnosis.
So why? Yeah. So why would an ARDS patient have hypotension? So what is that? Is a syndrome. That's not a diagnosis.
Yes.
ARDS is not a diagnosis.
Pulmonary edema.
Okay. Due to what?
Due to might be the excessive fluid might have given to the patient.
How much in a healthy adult, how much fluid do you need to? If I give you 20 liters of fluid, will you get into pulmonary edema? तो बियर पीते हो ना तुम लोग 20 लीटर तो पी जाते होगे नहीं
Then maybe heart failure might be there.
Okay. So heart failure and why ठीक है both forward and backward failure.
Yes.
So acute decompensated heart failure for sure, where you have forward failure with hypotension and backward failure with pulmonary edema. Fair enough. But in a trauma situation, in this patient, you have to give differential diagnosis for this patient, na?
And there may be any aspiration or any thromboembolism or dislodge.
Very good. So there could be a pulmonary thromboembolism.
Pulmonary thromboembolism because it's a post-operative decompressive craniotomy case.
He's a trauma. He's been lying in bed for more
Mm.
than 10 days in your
Oh, yes.
hospital, and he's not probably on any DVT prophylaxis. So the first thing that you're worried about is with hypoxemia and hypotension
Hypotension.
is embolism syndromes. What kind of embolism are you worried in this guy? Only venous thromboembolism or anything else also?
As there is long bone fracture also, there may be a fat embolism also, sir.
All right, fair enough, but too late for he's more than 10 days
More than-
post-trauma.
And-
So that's the third differential diagnosis.
And pulmonary embolism, any venous thrombus dislodgement, because he is a patient of bedridden.
Agreed. That's the second. That's already said. No? We said first is pneumonia with septic shock and ARDS. You can have sepsis from other sources. You can have it. ADHF is not right in an 18-year-old boy. So what are you looking at? Which will cause hypotension and hypoxemia. He's not going to have a cardiomyopathy from an ischemic cardiomyopathy. An 18-year-old man will have what?
Septic cardiomyopathy.
Sure. That's part of sepsis. So don't have to, it's not a separate diagnosis. You're giving a differential diagnosis. You have just given me one, which is pneumonia with ARDS and shock and septic shock. That's agreed. I agree with you. The first diagnosis is probably the right diagnosis. I'm not denying you that. I'm just saying what is second, third, and fourth. Second, you rightly said was pulmonary embolism or embolism syndromes. Fair enough. In this one, VTE is very much possible. Number three, you said is heart failure, but I'm just saying what caused the heart failure? Again, heart failure is a syndrome complex, isn't it? It's not a diagnosis per se. So did he have cardiac contusion? Did he have myocarditis from a viral fever? Does he have so contusion from trauma, polytrauma? Does he have any cardiac contusion to begin with? And things like that would be the more of a prominent thing. What other thing can cause hypoxemia and hypotension? May not be related to this patient, but say if this patient was under anesthesia and starts developing hypotension and hypoxemia and you gave cisatracurium, what would you be thinking?
There might be a pneumothorax in this patient.
Sure, delayed tension pneumothorax is a very good thing. Fair enough. But I'm getting to say this patient has a history of penicillin allergy. You started a new antibiotic and now patient is hypoxic and hypotensive.
Hypotension and in cardiac tamponade also we can see the hypotension and.
But hypoxemia क्यों होगा? होगा, हो सकता है, absolutely. If you have both right and left, this thing definitely. So tamponade, especially in a trauma patient, this is probably a delayed cardiac contusion. Delayed tamponade would be very likely. Yeah, agree. What else? I'm giving you a hint that the patient was given he's penicillin allergic and he was given a new penicillin antibiotic.
Anaphylactic.
Yeah. So anaphylaxis can cause both bronchospasm and as well as this thing. So these are the 5-6 differential diagnoses of a hypoxemia and hypotension. You guys should be able to list out life-threatening causes of hypoxemia and hypotension. Before the exam begins and we talk about what is the ARDS and things like that, if you're not able to give a differential diagnosis, then the exam doesn't proceed further in any exam, whether it's a DNB, DM or an IDCCM. That's what we expect you to know is what is a differential diagnosis. Because say if this X-ray comes back as normal, then you cannot now go back and after 6 hours say, no sir, sorry sir, we'll think about another differential diagnosis. You got to think of all the things and at the same time order appropriate tests at the same time to identify what is the problem in this situation. Ritesh, anything else you want to add?
Yeah. So as Dr. Suresh said, keep your mind open. See, because this ARDS session, You got stuck up in that ARDS point of view only, right? In exam, the same thing will happen. That you derive some conclusion, but the conclusion should be differential diagnosis. And see, there are hypoxia and hypotension, both are there. As Dr. Suresh has given enough hints, right? So favoring points and against points, you should be very clear in your mind. So okay, this is septic shock or pneumonia with ARDS. These are favoring points, these are against. Septic shock, these are favoring, these are against. Cardiomyopathy, these are against, more against. So if there are more against points, then don't speak upfront. The common things are more important, and history you only have suggested history. So don't, in exam many people tend to forget anaphylaxis. Many people. Okay, so I have 1, 2, 3, 4, 5. Never say symptoms when you are asked differential diagnosis, right? So I think we can go ahead.
On cardiovascular systemic examination, patient had S1, S2 present with no murmurs, upper abdominal, soft bowel sound present. Central nervous system, patient had altered sensorium, Glasgow Coma scale of E2, V2, and M4, bilateral pupil normal size and reacting to light. Initial assessment and early management, the patient had airway which was patent and clear, breathing.
Hold on. So how do you assess airway in a patient who's got a, how do you assess patency of airway?
By visualization, sir, if the, and also by we will ask the patient to talk if patient is able to talk or a cough out or anything. If there
This
are
patient, he was not talking, na? V2 or V1, kitna lik? How much did you write? What was the GCS?
no, we
So he was not speaking. He was only moaning and making some sounds. That is V2.
in
So how did you know that his airway is patent?
by examining the sir, if there is any upper airway obstruction is there or not, we can.
So you're looking for gurgling
No, for
sound,
visualization.
stridor, is there any pooling of saliva, all those things, which is what is required.
Snoring, very common,
No.
right?
Go ahead.
On breathing, bilateral basal crepitations present, use of accessory muscles present, patient required high oxygen support, planned for intubation and mechanical ventilation. On circulation, patient had blood pressure of...
Planned matlab? You didn't intubate him now.
Sir, we intubated him.
So why planned? You intubated and ventilated him. Or did you wait?
No. When the RRT call was given, sir, patient was on O2 support on 10 liters. So after that, we immediately we shifted the patient to the ICU and we intubated and took him onto the mechanical ventilation.
Why not BiPAP?
Already in a what they tried, sir, but like he is not maintaining the saturation. That's why.
And
No, he's got contraindications to BiPAP. Why? What are there not contraindications to BiPAP here?
But sir, he had low GCS.
Low GCS.
That's what I'm saying. So he has contraindications to BiPAP. So that's why you should not do BiPAP.
Yes, sir.
So
what about HFNC?
Yeah. Otherwise, what would be the cutoff GCS for intubation?
8, sir.
8 and less.
Less than 8 and
less than 8.
Less than 8.
So here GC scale is 8. Would you wait for intubation or would you give BiPAP trial? What would you do?
I'll go for intubation, sir, because in securing the airway, the patient might aspirate also. So in view of that, I will secure the airway first. Sir.
So please remember, there are two different things. The GC scale less than 8 for only and only protection of airway.
Yes,
Here we are not talking about only protection of airway. We are talking about ventilating the patient. All right. So you need to go ahead for intubation as early as possible.
Yes, sir.
How did you intubate? What drugs did you use?
By rapid sequence intubation, sir, by using fentanyl 1 to 2 mics per kg and by using rocuronium 1 mg per kg by pre-oxygenating we intubated, sir. Before that, emergency crash cot was in the site, sir, having all size tubes and with blades, with all blades available and bougie in hand, and also
Sure, fair enough. You prepared for a physiological difficult airway and you intubated the patient with fentanyl and rocuronium.
as
Did you apply Salix Manovir?
in rapid sequence intubation, yes, sir.
Is it recommended nowadays?
As there is no clinical evidence, sir, but we can use to prevent aspiration.
Did you use or did you not use?
We use, sir.
You use Salix Manovir?
Yes.
It is nowadays de-emphasized.
Yes.
All right. It may make your intubation more difficult. So have case-to-case base, and as far as possible, just go ahead with intubation. Go ahead.
On circulation, patient had blood pressure of 80 by 60 millimeter of mercury, a right jugular central line taken, and fluid resuscitation started. Disability, the patient was tuberous.
Hey, let me stop you. So what do you mean by fluid resuscitation started? What did you use? So how do you do resuscitation in this patient?
We use NS, sir, normal saline.
Okay, normal saline. So fair enough. How much?
At
At
30 ml per hour. We for initial resuscitation we use at 30 ml per kg.
So is that what you would do in this patient whom you suspect to be in ARDS? Is that what is recommended?
So the patient had shock, so that's why initially the patient had shock.
Correct. So, but that's what's called personalized medicine. So if you have a patient who is in shock and in ARDS, you don't know how much he's going to leak. So this is one of the places where 30 ml per kilogram is fine if you have a background of heart failure, background of CKD, but somebody who's in obvious pulmonary edema to you guys who's got bilateral clefts, maybe if you put an ultrasound, you'll have B lines. So when you're saying to me this, this is not how you resuscitate somebody in ARDS or with AKI where there's no urine. So when you do fluid resuscitation, remember the same thing, trawl, type of fluid, rate of fluid, what's your objective, what's your limits. So this is how you resuscitate. So you give, like in your dengue Government of India guidelines, go ahead and give small boluses and observe what's happening. If his oxygenation is worsening. So this is one place where you are going to give a small bolus of 500 ml over 10 minutes, start a vasopressors, look at the response and look at whether there is any danger sign happening of fluid resuscitation. So don't take this lightly in an exam and in life, because this is important. The concept of sepsis needs to be applied and know when not to apply 30 ml per kilogram. And this 30 ml per kilogram over 3 hours, isn't it? So there's obviously when you're doing this resuscitation in the early management, when you give fluid, you just say, I'm going to give about 500 ml of fluid, NS or RL over 5-10 minutes, and I'm going to start vasopressors and I'm going to get an arterial line to monitor the arterial blood pressure. And central line, if I require to start vasopressors at a higher dose. All right, go ahead.
So why not RL? Why NS? RL is more physiological, isn't it?
Because of the
So-
Sir, we can use RL also.
We can use, it's not like, what you have used and whether you would use RL or not. In majority of the fluid resuscitation, as per literature, maybe RL for initial fluid resuscitation when massive amount is necessary. RL is preferable, but please remember in neurological patients, RL is slightly hypotonic, right? And hypotonic fluid might cause further neurological injury, right? So be careful about in neurology patients, always with normal saline. All right. And as Dr. Suresh said, you have to have guided fluid therapy. So here, invasive arterial pressure monitoring is almost must. Right?
Yes,
yes,
sir.
sir.
Before we move on, I think this is a point because you intubated this patient correctly because patient's obviously breathing parameters using accessory muscles, poor GCS, hypotensive. So he's got all contraindications to do BiPAP. Say, but would you do a HFNC? And what is the guidelines for high flow nasal cannula in an ARDS in this kind of a situation? Do you think it's a okay thing to do or the wrong thing to do?
So based on the GCS, I won't go for HFNC, sir. But if we want to go for HFNC also, we should repeat ABG and we need to cross check, sir.
So let me rephrase the question. In non-mechanically ventilated patient with acute hypoxemic respiratory failure, which is not due to pulmonary edema or not due to AECOPD, how does HFNO compare to conventional oxygen therapy?
Sir, HFNO is, according to the studies, is better than the normal conventional oxygen therapy. It decreases the time of intubation, it delays the intubation, and there is decrease in the 90 days mortality.
The mortality decrease nahi hai, it just prevents intubation
And
So,
also,
as compared to standard oxygen therapy.
and also
There's no difference in mortality between high flow and conventional oxygen. If there was a mortality difference, then we would have said sabko high flow lagao na. So obviously it is not mortality different. That's why we are not saying. So why did your GCS make you stop giving HFNC? Why does the GCS have to do with anything with a high flow here? 8 GCS. He's got a patent and clear airway. इतना बढ़िया बढ़िया बड़ा बड़ा लिखा है. We've got a patent and clear airway. So why not high flow? Can you defend and say why you know?
So it might be in few if GCS might fall, sir, as it is gradually.
Sir, he had increased work of breathing, and the patient had low GCS, so he might aspirate. So that's why we prefer.
And also shock is ongoing shock.
Fair enough. So you got to put it in correct words. So you got to say that the clinical picture is that the patient is at present in distress. The work of breathing will not get settled without ventilation. He requires some sort of ventilation. And since he's hemodynamically unstable, the safest ventilation is by an invasive ventilation. That's the answer. And you don't have to beat around the bushes. Yes, high flow can be done if he was hemodynamically stable, if he was more awake and alert. High flow can be attempted, but if the PF ratio is again less than 150 or SPF2 by PF ratio is also less than. So what is the role of if you don't have? Okay, we'll go ahead. First, you go ahead. We'll talk next.
AVPU, patient responds to painful stimuli after ventilation. Patient was sedated. In ICU, day 0, the patient was intubated, sedated, and paralyzed, and was kept on mechanical ventilation. So, volume control ventilation with FiO2 of 100%, PEEP of 10, respiratory rate of 30, and tidal volume of 400. Protective lung mechanical ventilation strategies was applied, P plateau of less than 30. The focus 2D echo was done, which shows normal systolic LV function, no apparent right wall motion abnormality, right atrium and right ventricle appeared normal, IVC normal size and variation, distensibility index. IV fluid bolus given and vasopressor support was started.
I don't know, what do you mean? IVC normal size and variation plus or not plus? Distensibility index, how much should it be?
So, in a intubated patient, it is around 24%.
So when will you apply distensibility index and when will you apply collapsibility index?
Sir, in intubated, we will apply distensibility index, and in conscious patient, we will apply collapsing index.
All right. So how much should the distensibility index be? It's not 24%.
Greater than
Because you're given an IV fluid bolus based on the distensibility index. So I want to know how much was the distensibility that you decided to give.
It is greater than 40, sir.
Nah. 18%.
You don't know.
Okay, distensibility index of 18%. So IVC variation of more than 18 would tell you that distensibility of more than 18 would tell you that the patient will be maybe responsive. If it's normal size and definitely, or decreased in size and variation is significant, then yes. Again, but when you do a POCUS, what I would also like to see is what was the lung like.
Sir, I mentioned it.
No, what are the POCUS on the lung? Okay.
Sir, I mentioned about lungs. On sir focus lung, there was decreased lung sliding bilateral flaps point.
Okay. All right. So there were no B lines, nothing to suggest a pulmonary edema.
No, sir.
Okay.
So you didn't mention I ratio actually.
I/2 ratio. We kept
Uh,
starting, sir, we kept it for 1:2 only, sir.
So is there anything else that you can do? So this PEEP of 10, once the blood pressure was up, then and then you had kept, or in with presence of 80 systolic, you had kept PEEP of 10 to start with.
Sir, we too, as patient was in shock, we took on the vasopressor support, sir, and then we added once BP came above the 110, 120, and then we kept the patient on the PEEP 10, sir.
Okay, go ahead.
So this is the X-ray chest after the intubation of the patient, and this is the ABG report at 0 hours. The patient had pH of 17.397, PO2 of 70.1, PaCO2 of 50.3, bicarbonate 30.2, and lactate of 2.5.
Okay.
And these are the reports at that time. He had procalcitonin of 19.9, and he had higher counts of 15,500 and hemoglobin of 11.8 with platelets count of.
Go back on the X-ray. How will you read the X-ray?
So
this is an X-ray of patient AP view, sir. We showing the left lower lobe opacities are there, sir, on bilateral lung fields. In the lower side, it is there, sir.
Okay, so where exactly in the right lower lobe? Where?
Left lower lobe.
Left lower lobe. What about right lower lobe? Anything else? So is there can you see the right hemidiaphragm?
Right hemidiaphragm is, sir, elevated. Right hemidiaphragm is there.
Normal. Okay, can you see the right heart border?
obscured, sir.
Slightly obscured, sir.
Right. But the right hemidiaphragm is very clear.
Very clear, sir.
You got an infiltrate in the right lower zone. So
Yes.
where is the consolidation? Any idea? Which segment? Where? Any idea?
And in the middle lung, lower zone also it's showing.
And I'm asking segments. I'm not asking zones. That's all right. That's all right. That's a little bit of pulmonary, but it's a most likely if you can see the right heart border and the right lower lobe, it's a superior segment of the right lower lobe we're worried about. So in a guy with a low GCS, I'm worried about aspiration.
Yes.
For the left-sided infiltrates, the left mid zone is there an infiltrate, and you can't see the left hemidiaphragm.
Yes.
So there might be a silhouette. So fair enough. So he's got some patchy infiltrate on the left side and some right lower lobe consolidation. So, and how will you read the ABG?
And primary is the respiratory acidosis, sir. As pH is 7 point, PaCO2 was like 50.3, sir.
There is no acidosis. pH is absolutely
pH is
perfect.
compensated.
There's some hypercapnia. What else? How much of the bicarb is 30? So how come this patient was retaining CO2 from before? This is not an acute process, isn't it? Bicarb is 30, PCO2 50, and pH is corrected.
Yes. He was compensating.
But why was he retaining CO2 before to compensate? Why is the bicarb high?
Maybe.
So if this is an acute respiratory acidosis, how much did you expect the bicarb to go up by? And if this is chronic respiratory acidosis, how much did you expect the bicarb to go up by?
So for every 10 mmHg of PaCO2, sir, there will be in chronic 3 mm will be increase in bicarb, sir. If it is acute 1, there will be rise by 1.
So in this situation, what has happened? Bicarb has gone up by 6.
6.
So what does this tell you?
It's a chronic.
That there is a concomitant
Metabolic.
Concomitant metabolic alkalosis is there, sir, in this patient.
So there is a,
and it's a chronic one.
or can I tell you, or can I ask you the other way around? This is only metabolic alkalosis. What is the compensation in CO2 for metabolic alkalosis? For metabolic acidosis, you guys all know. For metabolic alkalosis,
Point 8.
So in ICU, what is the commonest cause of metabolic alkalosis?
Dehydration might be the cause, sir.
Yes.
so what is the compensation formula for metabolic alkalosis? So how much should the PCO2 be? Change in PCO2 for every 10 in every 1 milliequivalent increase in bicarbonate. So bicarb has gone from 24 to 30. So 6 increase. So what did you expect the bicarb to be, PCO2 to be?
6 for if it is chronic. Totally it should be around 75 around, sir.
Oh, bakawas. Don't get me started on this.
The formula will be this a 0.7 into bicarb plus.
So 0.7 for delta. So delta bicarb is 6. 6 into 0.7 is how much?
4.2.
So PCO2 should have been 44. So there
44.
is definitely, so there is a anytime the pH is normal and you have an abnormality, there is definitely 2 process going on, isn't it? Or a triple process. So here you have a respiratory acidosis and a metabolic alkalosis going on here.
Yes.
All right. This ABG should be diagnosed. 1 second, my dog, I need to pet.
Go ahead, please go ahead.
This is an HRCT on day 3, which revealed right segmental consolidation with left complete collapse.
So what was the FIO2 during that time when you decided to transfer patient for CT?
FIO2 is on 100% only, sir. We are tapping gradually.
So now we know that this is not a patient of ARDS, isn't it? Now you have made very clear. So let me ask you, can you tell me the Berlin criteria for ARDS?
So with the Berlin criteria, it mentions onset, which was acute in onset within 7 days of with risk factors, and the patient had bilateral opacities present in the CT or chest. The patient it also classified.
Pura batao. No. I'm going to stop you there. So timing is fine. Onset of respiratory failure within 1 week of a known insult. एक दिन का fever था, fair enough. Imaging, bilateral opacities on chest CT, not fully explained by?
Not fully explained by fluid overload, heart failure.
No.
Not fully explained by pleural effusion, nodules, and collapse.
There you go. So now your answer is this is not a patient of ARDS. Anna? Am I right or not? You just answered the Berlin definition. So this is not a, you are not presenting to me an ARDS case. Yashoda Hospital would have done an interventional pulmonologist, would have jumped, bronzed the patient and gotten better in 2 seconds. I would have also done the same.
Isn't it?
So you have now defined to me ARDS and you have now agreed that the imaging finding, everybody should know this is not ARDS. Okay, this is classical of not ARDS. Because you just defined it. Go again. Repeat the imaging finding for all the students who are listening now.
It revealed right segmental consolidation with left complete collapse.
So now repeat the definition of imaging for ARDS.
Bilateral opacities present, which was not consistent with the.
Not fully explained
Not
by.
fully explained with the pulmonary pleural effusion, consolidation, and nodule.
Not fully explained
collapse.
by pleural effusion, collapse or nodule. So here it is fully explained by collapse. All right. So this is 100% not ARDS to me. Now, if you give PEEP to this patient, he'll get better because you're opening up the collapse a little bit, but this is not ARDS. You cannot present this in any meeting or to me or anywhere else in the world and say this is ARDS. Because I'm going to quote you as a lawyer. I'm going to quote you. Please again, Dr. Saab, सबके लिए बताइए, जोर से बोलिए, how do you define imaging ARDS? All right, please, everybody. Okay, for the sake of discussion, we'll continue that, but this is not ARDS. Please, everybody should be able to recognize this. Please refer to, if you cannot do a bronchoscopy yourself, please refer to a pulmonologist who can do a bronchoscope on this patient. Even in that 100% oxygen, we definitely can open up the left, both the right. So even for me, right segmental basal segments are collapsed, medial basal segment is collapsed, and the left lower lobe is completely collapsed. So this is a good candidate for, this is one of the only indication for doing therapeutic bronchoscopy in the ICU. All right, but for the sake of discussion, we will assume that this, take off this X-ray, delete this slide and go move on.
Let's go ahead.
On focus lung, there is decreased lung sliding bilateral collapse point. The patient was started on empirical antibiotic therapy after sending the blood and ET endotracheal tube and urine cultures. Injection meropenem, injection poly-B, injection clindamycin, and new nebulization with colistin was started according to our antibiogram. Repeat ABG was done after 1 hour of ventilation. The patient had pH of 7.258, PO2 55.8, PCO2 of 65.6, bicarb of 24.4, and lactate was 4 on 100% FiO2 and had PF ratio of less than 0.5. Murray score was also done and the patient's score was 3, so ECMO team was also alerted. Ventilator settings were adjusted as per ARDS net protocol. PEEP was optimized, settings was FiO2 of 100%, PEEP of 12, respiratory rate of 35 and tidal volume of 420. Compliance and driving pressure improved, PEEP-led ensured, less than 13. Recruitment maneuver was once attempted. And for ECMO team also alerted after a Murray score. Non-contrast CT had done on day 2, post-operative changes, no bleeding or edema, conservative management plan.
Just hold on.
Yes, sir.
All right, you got that. So I just going to ask you, can you tell me the ARDS net protocol? You can show the next slide. Fair enough. So you do a low PEEP or high PEEP one. Which one do you do? How do you set?
We use in ARDS net protocol, so we use low tidal volume and lung protective ventilation we use, sir, and gradual
Good.
increase in PEEP we do, sir.
So no, gradual. So there is a table for 100% oxygen. How much PEEP would you give?
18 to 24, sir.
Fair enough. So that's not a gradual. So if you're on 100% oxygen, your diagnosis is ARDS. I just dial up the PEEP to 20, isn't it?
Yes.
So because so by definition, your PF ratio was less than 100, isn't it? So by that definition, this is severe ARDS. Right. So severe ARDS, PF ratio less than 100. So you're gonna give a PF ratio, PEEP of 18 to 24. That's your lower PEEP group. Fair enough. And tidal, what do you mean by lung protective ventilation?
Low tidal volume we use, sir, which is of by predicting predicted body weight we use like 4 to 6 ml per kg.
Or the initial is also 4 to 6, or how do you start off?
By checking the plateau pressure, sir, we keep the plateau pressure less than 30.
No, the initial tidal volume is 4 to 6 or 8.
Initial, we can go for 6 ml per kg, sir, and then we will decrease gradually.
It is written, Baba.
Initial,
It is written on
is
number
80,
3.
sir. Initial is 8.
So initial is 8 ml per kilogram, and then you reduce the tidal volume until you get until tidal volume is about 6 ml per kilogram of predicted body weight, and your initial respiratory rate you adjust based on the pH.
pH
Yes.
means.
And your plateau pressure goal is less than 30. How do you check plateau pressure?
Plateau pressure by giving inspiratory pause for the 2 to 3 seconds.
2 to 3 seconds. Yeah. Who gives a 2 to 3 second hold? If the patient is set at 20 breaths per minute, every 3 seconds का breath है, उसमें 3 second का pause करोगे.
और respiratory rate तो I think 30 set किया हुआ है ना.
So 2 seconds, your total inspiratory cycle is 2 seconds. How do you give a 2 second pause? See, this is the problem with the automated machine. Nowadays, you don't have to do anything. You just press the button on the newer ventilators. So on an olden ventilator, you had to press for some time. And you have written it down. It's down there at the bottom. Check plateau pressure, P-plat, 0.5 second inspiratory pause.
Yes.
It's there on your slide.
Yes, sir.
Right, you got to do this. What else do we suggest that you monitor for lung protective ventilation nowadays?
So driving pressure.
Driving pressure. Alrighty. So what is driving pressure? What is the formula for driving pressure?
Plateau pressure minus PEEP, sir.
Okay. So how much should that be?
It should be less than 15, sir.
So that's another goal that you have nowadays. So why the other question? So go back to the previous slide. You said PEEP optimized. How do you optimize PEEP?
Gradual decreasing.
That's not. So gradual increase is not optimal. That is bad. So what do you mean by optimal PEEP? What do you understand by, let me rephrase the question for you. So you have set the patient with either the Gattinoni rule or the ARDS net protocol rule, and you have set a given PEEP. Say you're given 16 and you're on 100% oxygen. Dr. Ritesh walks in and says, this is not optimal PEEP. So you got to ask Dr. Ritesh, sir, what do you mean by optimal PEEP?
How many PEEP actually you know about definitions? One is
P,
optimal PEEP. Anything else?
auto P,
अरे नहीं रे बाबा. Maximal PEEP, escalating PEEP,
escalating P.
de-escalating PEEP. So optimal PEEP, what is your target?
To increase the compliance.
Okay. So one of the
Increase
ways in which saying is compliance, best compliance. The one PEEP which gives you best compliance.
Best
Any other
compliance.
definition?
And less less hemodynamic compromise will be there.
All right. So PEEP which gives the least amount of hemodynamic compromise. Okay. Anything else?
as a primary purpose of PEEP.
Yes, sir.
What is the primary purpose of giving PEEP?
To prevent it from
To decrease the shunts are mainly.
So what's the effect? What's the effect?
To increase the oxygenation mainly.
Exactly. So the primary purpose, see PEEP, that means the advantage should be there and the disadvantage should not be there. That's what is called optimal, right?
yes.
So adequate oxygenation is there without injuring the lung, right? So that's what is called optimal PEEP. And without injuring means you get better compliance. That's one. What is the other thing you said?
Less hemodynamic compromise.
Less hemodynamic compromise. So you need to titrate in one way hemodynamics, other oxygenation. All right.
So PEEP guided by respiratory mechanics. Have you known? Do you know of any studies which have looked at it? Which is what you said first, na, Dr. Rohan?
Yes, sir. Sir, high PEEP, low PEEP trial, alveoli trial.
So there are four major trials. The first one was EPVENT trial. This time in Criticare 2024, you had the original author of EPVENT come in. Isn't it from Boston? Then you had EPVENT 2, then you had the ART trial, then you had the Pintado study. So the four studies which have majorly compared a mechanics-based or a respiratory mechanics-based versus a standardized PEEP FiO2 ratio, and none of them have shown any. In fact, ART trial has shown. ART trial was published in JAMA in 2018. Please read that. It's a recruitment plus PEEP based on respiratory mechanics. It showed an
increased chance of trauma with the barotrauma.
Increased mortality. Showed an increased higher mortality. So therefore, recruitment maneuvers are no longer advised, isn't it? So PEEP, optimal PEEP means three definitions: the hemodynamic, respiratory mechanics, as well as best oxygenation. So best oxygenation. So how much oxygen do you want? So how else? What else? So, but what we mean by PEEP optimal, a lot of people also mean is that the one which prevents ventilator-induced lung injury. So how do you think PEEP mitigates ventilator-induced lung injury?
Prevents alveoli to collapse.
Okay, so that is called as
barotrauma. It prevents barotrauma.
It leads to barotrauma because you're increasing pressure.
It decreases over distensions are made.
No, said it basically leads to prevents the repetitive opening and closing of the alveoli, which is called atelectotrauma. What else does it do? It promotes more homogeneous ventilation between the alveoli because of opening, but therefore preventing shear and strain injury to the lungs. Okay. And it increases the number of aerated alveoli participating in gas exchange. So therefore, again, increasing the compliance of the lung. So it creates benefits by mitigating villi and it improves oxygenation by decreasing the compliance and decreasing the atelectasis. So that's how PEEP works, and PEEP mitigates villi. And optimal PEEP, you need to know these definitions. And what is your opinion on recruitment maneuver? Should be done, should not be done? You said once attempted.
Sir, according to studies, one study was ART study was done. So it shows that there is increased chances of barotrauma with the recruitment maneuver.
So what kind of recruitment maneuvers do you do in your ICU? Why did you do it if there is increased mortality? And what does the ESICM guidelines say?
So there is we do a stepwise increase in the PEEP and we'll wait for 2 to 3 minutes for its compliance to check its dynamic compliance.
Can one of you define recruitment for me?
In recruitment, I mean, generally use the gradually.
Define it for me. Define. So before you treat something, define it.
Sir, for recruitment to preventing it from collapsing and over distending alveoli.
Recruit, that is called lung protective ventilation. What you're saying is that's called lung protective.
Open lung ventilation.
That is to keep the lung and keep it open. That's open lung. Recruitment is, yeah. So this patient actually needed recruitment, but by a different method, isn't it? He has a collapse. So recruitment means re-expansion of previously collapsed lung area by means of a transient controlled increase in transpulmonary pressure. This is the definition that you guys should be aware of. It is a opening up of the alveoli by a transient controlled increase in transpulmonary pressure. All right. So you can increase the transpulmonary pressure by doing a staircase recruitment, which is what you are talking about. The words we want to hear in the exams, sir, it's not that we increase PEEP gradually. The method has a name. It's called a stepwise recruitment maneuver.
Yes, sir.
So it's a stepwise or a staircase recruitment maneuver. That's what we use, sir. That's what is recommended. So we gradually go up, and at the best optimal PEEP, then we start gradually decreasing like a staircase or a stepwise. So that's what we do. We don't use the 40-second CPAP for 40 seconds. We don't use any of those maneuvers anymore. High inflation, especially what was used in the ART trial for more than 3 minutes, those are completely harmful, sir. That will cause barotrauma. So the answer in this in real life, when you explain to somebody, is recruitment maneuver is a opening up of collapsed alveoli by increasing transpulmonary pressure for a controlled manner. How do you do it? As of today, we do it by a stepwise recruitment maneuver. And what is the recommendation? The ESICM and every college doesn't have any recommendation because it's harmful mortality. It does briefly improve oxygenation, but does not change outcome. These few lines you should be able to say that so that you can understand about ARDS, right? And before you alerted the ECMO team, what should have been done? After recruitment, after optimizing PEEP, before Murray score being done, ECMO team being alerted, what should you have done?
Prone positioning.
So why did you not prone this guy?
Sir, he
patient is a decompressive craniotomy case, a raised ICP.
Risk of raised ICP, and he had fracture.
You are recruiting somebody with a transient elevation of ICP of transpulmonary pressure to such an extent, but you're afraid of and you're giving 20 of PEEP. So what is the contraindication to proning?
Sir, he also had fracture of the right humerus.
Right?
Right humerus.
That you said has already been fixed.
So shoulder reduction was done, right? Humerus fracture was not operated at that time.
Okay. All right. Fair.
To allow worsening of the patient vis-a-vis taking care of shoulder.
Yes, sir.
Please, sir.
So you were afraid that if you were to prone him, his shoulder will dislocate again.
So both the factors was there, sir. He had raised ICP, risk of raised ICP, and also he had fracture of the right shoulder. So that's why.
So,
Raise ICP, is there anywhere written that it is contraindication for proning?
Sir, it's a relative contraindication.
but this is a guy with a this thing. So, okay, the question is, how do you manage say ARDS with raised ICP? So if this patient had an acute, say this guy had come in within 2 days, did not have a decompressive craniotomy, what would you have? What is can you go up to PEEP of 20?
No, sir, it will be more harmful if we go up PEEP up to 20.
So then you did PEEP of 20 in this patient. 24 you went up, 22 you went up. Because if you looked at, you went up to 12.
Yes, sir.
So why did you use 12 as a limit? Because you're not setting as per ARDS net protocol, isn't it? Your settings of 100% FiO2 with PEEP of 12 is not according to the ARDS net protocol. You have written ventilator settings were adjusted as per ARDS net protocol. You didn't do that. You have written 100% FiO2 and 12 PEEP. But at 100% FiO2, the simple rule of thumb is FiO2 divided by 5 is equal to your PEEP. So if you're on 100%, 100 divided by 5, 20 is your PEEP. That's how we are taught the ARDS net score. So if you're on 80% divided by 5, 16 is the PEEP. If you're on 60% divided by 5, 12 is your PEEP. That's how the ARDS net is, score has come up, ARDS net table has come up basically divided by 5. Isn't it? So you're not doing according to protocol here. So if you're not doing it according to protocol, you're afraid of, I raised this thing. So if you're in a neurocritical care unit of any other place and you have a trauma with ARDS and with brain trauma and with lung trauma and you had ARDS, how would you guide your PEEP in a neurocritical? I understand this is not your question and I'm just going ahead and asking you a question in a neurotrauma because you are now in a day 10 post decompressive craniotomy. The guy should not have raised ICP. Why are you worried about it? तुमने निकाल तो दिया. Your skull is out. What kind of ICP will get raised? And if you are and how does PEEP lead to high ICP? Or how does intrathoracic pressure lead to high ICP? So who told you? Your neurosurgeon told you not to give PEEP or you decided not to give PEEP on your own? So intrathoracic pressure, when it rises up, it will has the same thing of decreasing the venous return, and therefore, you want the head end of bed up. So what in prone position or any of these things is a relative thing, because when you keep the patient supine, your venous return is decreased, and if you give a high PEEP, your venous return is decreased. So as long as your venous return, as long as you're watching your RV, and as long as your RV is not getting affected, you are fine with the PEEP. So that's when we take about optimal PEEP. Nowadays, the term is called as the PEEP which protects the right ventricle is called as the optimal PEEP, not hemodynamics. So therefore, when you do focus on these guys every day in ARDS, what we are supposed to do is look at the RV, look at the TAPSE, look at whether the RV is dilating, look at whether the TR jet velocity is increasing. All right. So that's what you're supposed to be doing when you're doing an optimal PEEP. Right, and this is one place in where you would absolutely do that. Okay, you would tend to monitor with either an NIRS or a jugular venous bulb saturation to make sure that your tissue perfusion to your brain is okay when you're doing proning or you're doing high PEEP. So anytime we say that any PEEP more than 12, which is why you have used here, I think neurosurgeons have memorized that number. They know that number more than you do, that any PEEP more than 12 needs to be done only with the close monitoring of cerebral circulation. So that's why you have kept a PEEP of 12. All right. So in the exam, if this is a if you're in a neurocritical care exam, we would ask you how do you set PEEP? So you set PEEP while monitoring but you should be able to answer why PEEP is harmful for the brain and why you are a relative contraindication for proning, isn't it? So that you should be able to answer. All right. So ECMO, what is the Eolia criteria for ECMO?
So there is no certain benefits in Eolia criteria.
No. I'm just asking you, what is the criteria used in the Eolia trial which we should use clinically to guide our patients? कि ECMO लगेगा कि नहीं?
PF ratio of less than 80 on FiO2 of more than 0.9.
So, if there is PaO2 by FiO2 ratio less than 80 for greater than 3 hours, despite giving the PEEP.
Correct. Go ahead.
And also,
so a PF ratio remains less than 80 after 6 hours of attempting both prone as well as every recruitment, optimizing PEEP, everything. Despite that, if after 6 hours, if your PEEP is still less than 80, or if your respiratory, you're not able to, on 4 ml per kilogram also, if you're not able to keep the plateau pressure less than 30, or your respiratory mechanics are a problem, or if you have respiratory hypercapnia and acidosis, which is not getting corrected despite maximal recruitment and maximal respiratory rate. So this is what, so if your pH is less than 7.15 despite respiratory rate of 35, think of ECMO. But we know that both for hypercapnia as well as for hypoxemia, the Eolia did not show an improvement in outcome, but there was a lot of crossover, so it is an indeterminate trial. All right, go ahead.
Course during ICU stay from day 2 to day 7. Blood culture showed Acinetobacter pulmonary crab growth with similar pattern in ET aspirate. Same antibiotics were continued after cross checking with sensitivity report. PEEP was optimized and FiO2 was titrated as per ARDS protocol after each ABG report. Intermittent fever spikes was present. Sedation and paralyzing agent were stopped and planning for gradual weaning after day 3. Patient showed gradual improvement after second day. Prone ventilation was not done due to craniotomy defect and risk of raising ICP during proning. On day 2, his pH report was ABG report was pH 7.343 with PO2 of 84, PSU2 of 35.87, bicarb of 21.6 and lactate of 2.7 with 60% FiO2. On day 3, the patient had improved pH of 7.376 and PO2 was 78 with PCO2 of 39.82 and bicarb 24.4 with lactate 1.3 and FiO2 of 50. On day 4, pH was 7.42, PO2 64, PSO2 of 36 and bicarb was 24.8 and lactate 1.2 with a FiO2 of 35. However, patient showed improvement with given antibiotic and ventilation strategy. Paralytics stopped on day 4, sedation stopped after 6 hours, and kept on intermittent sedation afterward as needed.
Why did you take such a long time to stop paralytics? Because he is not prone. So is there any data that after 48 hours, paralytics will help you? So the accuracy study showed what?
48 hours, cisatracurium.
Why did you decide to double it?
Because
and from the petal group, the Rose study showed any outcome benefit of this also?
no,
No,
sir.
So then why?
But
Why you said 96 hours instead of 48 hours?
Because
Suresh, I'm sorry, I need to leave.
Oh,
Uh,
okay.
Yeah, please continue. Please continue. Sorry, sorry.
Okay.
I'll connect you later.
Yeah. Okay. Thank you. Thank you,
Right,
Dr.
uh, to prevent patient ventilator asynchrony, sir, if there is.
Is there any data that deep sedation is not good enough? All right, please get away from this wrong practice. Deep sedation is fair enough. So you keep a RAS score of -3 to -4. Deep sedation, that should be good. All right.
Course during ICU stay, regular chest and limb physiotherapy was started during the weaning period. Patient developed critical illness-related weakness and weaning failure. Tracheostomy was done on day 7 to facilitate weaning from ventilation. Afterward, patient was weaned intermittent portable support ventilation and discharged with continuation of same care. This was the investigation on day 8. Urea of 27.6, create 0.3, calcium 8.7, magnesium 1.2, and phosphorus of 3.7. Follow-up post day 7 post discharge. Patient was vitally stable, had improvement in GCS to E4, VT, and M6. No episode of fever. Patient was able to hold airway secretion and oral feeds. Daily chest and limb physiotherapy, tracheostomy care was being done. Respiratory muscle strength not adequate, hence again advised to continue with trach and mechanical ventilator support. Patient was finally decannulated after 1 month of discharge and advised for continuation of rehab and care support.
All right. I think we covered most of the points. I think
Yes.
I think the most important point was that this was not ARDS.
Yeah.
All right. So I think fair enough. I think this is a very illustrative case to understand the Berlin definition.
Yes.
We got to ask that and say because it is explainable by collapse, and collapse atelectasis is the commonest cause of shunt physiology. So will produce the same decrease in PF ratio, will produce the same thing. We talked about, so the definition is important. The SPF ratio is important. Now that in a resource definition, the newer, please read the Blue Journal definition of ARDS in resource limited countries and in patients on HFNC, more than 30-liter flow. So there are 3 definitions of ARDS: ARDS in normal countries, ARDS in patients on HFNC, and ARDS in resource limited countries. So all the definitions are not only the Berlin criteria, the Kigali modification, and this newer definition should be known to all of you. And you should be able to apply the definition, which is what was lacking in this case, which is what you guys should do, is able to recognize that this is collapse and then be able to take care of it. Use the ARDS net protocol or the Gattinoni formula, that is for mild ARDS, use 5 to 10 p, moderate 10 to 15, and 15 to 20. Otherwise, use the ARDS network treatment for low tidal volume and this thing. Optimal PEEP is an important question. Optimal PEEP now we say is based on how it is affecting your RV and how it is affecting your compliance, but compliance data is not no evidence to say that it should be driven by compliance. So how to select PEEP, how to measure the inspiratory pause are things, and how to measure the plateau pressure, how to calculate driving pressures, what are the indications for prone, how does prone ventilation help, what is the role of paralytics, what is the role of other modality, what is the Eolia criteria for ECMO. And these are all the recommendations, and you can read there are 2 recommendations, one ESICM recommendation on November 2023 and the January 2024 AJRCCM recommendation for ARDS management. Should be must read before the exam because those are the recommendation. India has participated in it. Sheila ma'am has written the paralytics in ARDS, that is her contribution. And I think Dr. Ramakrishnan from Apollo Chennai has written the AJRCCM part. So we have significant contribution from Indian authors and Indian researchers. So I think you guys should, all the exam going students should look at those 2 articles. I suggest Dr. Kaladhar, if you can please make sure that those 2 articles are disseminated to all the
Sure, sir.
all the students, that will be great. I think that minimum reading before the exam so that they are in one way able to answer what is the role of PEEP, what's the role of recruitment maneuver, what's the role of paralytics, These are all just, you read the recommend, as per the recommendation, this is it. Just come out with it quickly. And obviously, then when you present, there will be certain issues. The ability to form a differential diagnosis is where you get diverted in the exam. And you should be aware that, yes, you know it is pneumonia and ARDS, the questions, but you still should be able to formulate a differential diagnosis. You will come out and say, Suresh sir failed me despite the fact that I knew everything about ARDS, because I'm not going to let you become a good consultant because you couldn't tell me any other cause of what is happening to the patient. A good doctor, you have to be first, and then yes, now after that, even you can look up the book and you know what to do for when to prone, what's the Eolia criteria. What you need to be on that particular time is be able to formulate a differential diagnosis, send appropriate investigation to rule in or rule out other things, and therefore take care of patients. Because if it is not, so in this case, if you didn't refer to a pulmonologist or yourself did not do a bronchoscopy, it's not probably helpful for the patient. But I'm not, as I said, I might be wrong in this situation. I'm just guessing from what you're showing me on the XCT scan, but keep your mind open. Keep your mind open when you come to an exam. Otherwise, well presented, and the case was interesting, very well managed.
Thank you, sir. Yeah, thank you for sharing your clinical insights, sir. Suresh Ramasubban, sir. So thank you, Dr. Rohan and Harish, for presenting the case. I think any final, what do you expect from, suppose the DRNB or DM candidate appearing for exam? Any final tips from you, sir? Generally, they are there on exam.
Correct. I think I said my first impression is when my impression is unfortunately formed when you're not able to. I'm MD medicine, isn't it? So I have a bias that if you don't form a good differential diagnosis, and that's unfortunately a little bit of a problem for people coming from anesthesia background or chest background. You don't have the habit of coming with a difference. You see it is ARDS and you close your mind to it. So I definitely expect that, when you come into you as a medicine, because critical care medicine, so I expect you to come up with an open mind, come up with a differential diagnosis. And as Dr. Ritesh was saying, in your mind, say what are the points in favor of this and what are the points not in favor of that, and then go with an open mind. And that's important. And then once you say ARDS, we expect you to have the definition memorized and, and full definition. You kind of say the imaging was only bilateral infiltrates and you forget the remaining, which is the most important thing in this case, which is what I pointed out to you. So it's important to look at that and say, and then then again the thing, what are the mimics of ARDS, which we did not talk about, organizing pneumonias and things like that, AIPs, acute interstitial pneumonias, and so on and so forth, acute eosinophilic pneumonia. So that is something. And then stepwise management, when you use the word optimal PEEP, you shouldn't define it. So you don't use any word and don't say, sir, I increase the PEEP. Use the word stepwise recruitment. So this is a stepwise recruitment maneuver that we use, sir. So these words have to be the correct, because if you use the right word, I'm assuming you have read and I'm assuming you have memorized and I'm assuming you do it. If you say something like, sir, we vaguely increase PEEP, I'm imagining you were standing way behind when the consultant was changing the knobs. So you are not really doing it yourself. So we can make out how much you're doing and how much you're actually seeing people do and how much you have listened just to conferences by the way you answer. So we get to know how these are, because we've been taking exams for many years now and giving exams for many years also. So I think we have an equal experience of 20 years of giving exams and 20 years of taking exams now. So I think it works both ways. So it's important to use the right word, because you use the right word, the examiner is very happy and he just moves on and he tests you for more things. If you use, sir, we use this much PEEP, that much PEEP, then I'm going to question you, how does PEEP work? What does PEEP? Then, you get into the nitty-gritty details of things like that. So if you use stepwise recruitment and I know that you're understanding how you're doing, I move on. So we use specific terms. It's very, very important. This what is called semantics are very important in exams. You got to use the right word to please the examiner and to tell the word that you know it. And remember what Shakespeare said, brevity is the beauty of language. And brevity, that means how quickly you say. If you say stepwise recruitment maneuver, I'm not going to ask you anything. If you say, sir, PEEP this way, that way, I'm going to ask you something. So brevity, using precise language, is absolutely essential in an exam. And these are keywords in what we write in MCQs. These are keywords. And in real life, when you give a Viva OC, these are key, again, very important words, which will make sure that the examiner knows. That means we are on the same page. The moment you say stepwise recruitment, I know you're in the moment you say Eolia criteria, oxygenation, hypercapnia, and respiratory mechanics. I know we are on the same page. You don't need to, I don't even ask you what is underneath that subheading. So Eolia had 3 criteria. One was an oxygenation, one was a mechanics, and one was a respiratory acidosis criteria. And that's it. So we move on. And then the question is, have you done any ECMO? What does you feel? And then you will chit chat and you pass the exam. The more you make me ask you things, you will not pass the exam.
Correct, sir. Rightly said. Yeah, correct. Yes, sir. I think we come to the conclusion of our webinar. So thank you. Really, those points are very helpful, sir. So thank you, Dr. Rohan and Dr. Harish also. Thank you, Yashoda Hospitals and Hyderabad IDCCM chapter and our digital team for providing the platform for regularly conducting these classes. Thank you, sir. Good night.
Thank you, sir. Thank you.